Thank you, Tiara, and hello to everyone out there. This is Sheila Pyrus, and I'm a core partner with the National Technical Assistance Network for Children's Behavioral Health. We're happy you're joining us on this webinar on care coordination approaches for children with moderate to intensive behavioral health challenges. In a moment, I will introduce our other presenters, but I wanted to just provide this commercial that this webinar is hosted by the National TA Network, which is funded through the Substance Abuse and Mental Health Services Administration. I also want to point out that this webinar is one of a series. It's the third in a series that we're doing that we're based on an expert convening that we brought together on the topic of care integration in primary care for children, youth, and young adults with behavioral health challenges and their families. And on this slide, you'll see the links to the other webinars that were done that are built around a consensus framework that came out of this expert convening. And the care integration continuum framework that people have sort of agreed to at this meeting is one that, first of all, people said should be nested within common values and principles, and they're very much like system of care values and principles that they identified. And that across the continuum, because we're talking about a care integration continuum for a total population of children and families, that there should be family and youth access to family and youth peer support and system navigation, and that there should be metrics, measurement. It should be a measurement-based system, so with measures across the continuum. And if you look at this graphic, and you start with the far left-hand box, the recommendation was that for all children, there should be screening, and typically that takes place within primary care practices, and the promotion of a social and emotional development, and attention to what in the healthcare field today, I'm sure you've heard this repeatedly, are the social determinants of health, the kinds of things that have a bearing on well-being, like housing and safety, etc., in addition to health and behavioral health care issues. And then for children with identified behavioral health needs, as you move across the continuum, the recommendation that there would be child behavioral health consultation programs, which is consultation to primary care practices like the MCPAP program in Massachusetts, and to early childhood settings, preschool, Head Start, etc. And the first webinar in this series featured a couple of programs that were doing child behavioral health consultation programs. Then as you move across the continuum, for children who have low to moderate behavioral health needs, people recommended the use of team-based care coordination approaches, such as in the collaborative care management approach that Jacksonville, Florida is using and will be presenting today. And that for children who have significant behavioral health challenges, who often typically are involved in multiple systems, that the only approach that the group could identify around which there's evidence is intensive care coordination using a fidelity wraparound approach. So today's webinar is really focusing on these last two boxes, care coordination approaches for children with low to moderate needs and those with significant behavioral health challenges, just to kind of orient you. We'll be providing some brief contextual information about this population of children, which is probably already familiar to you. Then Dr. Faluco will be talking about a collaborative care approach that they're using in Jacksonville, and Shamika Williams from Oklahoma, who's going to be talking about their health home approach, which is serving both children with intensive service needs and those at very high risk. So our presenters, in addition to myself, include Elise Faluco, who is a child psychiatrist with the University of Florida College of Medicine in Jacksonville. She's chief of the Division of Child and Adolescent Psychiatry and the training director of the Child and Adolescent Psychiatry Fellowship Program. She's also director of the Collaborative Care Initiative that she'll be focusing on today. Shamika Williams is the senior director of the Oklahoma System of Care, which is the lead for which is in the Oklahoma Department of Mental Health and Substance Abuse Services, which has partnered closely with the state Medicaid agency in Oklahoma, and particularly around the development of their health home approach. So we're delighted that both of them could join us today. So I'm going to provide just a brief context setting, again, just to kind of orient us. As you know, about 1 in 5 children, if we talk about prevalence data, that 1 in 5 children will experience a mental health disorder in a given year. 1 in 10 is expected to meet the federal definition of having a serious emotional or behavioral health challenge. And 1 in 6 has been estimated to meet the criteria for a diagnosis, who don't meet the criteria for a diagnosis, rather, but who need support to address emerging risk issues. And where intervening early is so important. We think particularly about the population of young children birth to 5, who often don't meet the criteria for a diagnosis, or for whom families and clinicians are reluctant to give a diagnosis or label a child at such a young age. So if you think of this triangle from a prevalence and utilization standpoint, from a prevalence standpoint, if it represented all children in Oklahoma, let's say, 80% would not have a need for specialty behavioral health care. But some 20% will, and some 2 to 5%, which could be higher based on your demographics, and it's probably a little higher in the Medicaid population, will have a need will have more serious and complex behavioral health challenges and often be multi-system involved. So from a utilization standpoint, what often happens in states is that sort of top of the triangle group of children end up using very intensive services, often facility-based, like residential and group care, or bounce in and out of psychiatric hospitalization. And that leaves, and those are expensive services, so it's leaving less for more supportive home and community-based services, and it leaves almost nothing for prevention and universal behavioral health promotion. And so a lot of the initiatives out in states, including system of care initiatives, are trying to change this triangle and increase access and the availability of evidence-informed home and community-based services and reduce reliance on out-of-home placement. Okay. So for lots of reasons, including the use of more restrictive, expensive services, children in Medicaid are, in general, children who use behavioral health care are an expensive population. And we talk about expense because as someone who does a fair amount of work with state Medicaid agencies, it's often a way to get attention to a population that may not necessarily be on their screen, because state Medicaid agencies have a lot to pay attention to, are often focused on adult populations and those with chronic and comorbid physical and behavioral health conditions. But children in Medicaid who use mental health care actually have higher expenditures than adults with serious mental illness. And unlike adults, their expense is driven by the use of mental health services, not by physical health care. And that has an important bearing on how one organizes care coordination approaches. These children are not as healthy as children in general, but they just don't have the same very high co-occurring rate of comorbid mental health, of comorbid physical health issues as the adult populations. And if they do, they tend to be things like asthma, for example, and not, there's a much lower incidence than in the adult population of things like heart disease or cancer or things that are very expensive and difficult to manage. This population of children with serious mental health challenges also are different from adults in that they're involved in systems, and typically, you know, 2/3 of these children at least will be involved or very high risk for involvement in other systems. And those systems have legal mandates to serve children in a way that adult systems, except for adult corrections, really don't. So if you think of the child welfare system or the juvenile justice system or special education, there are legal mandates. So it's really difficult, and it's not impossible, I would argue, to develop a cohesive plan of care without paying attention to what's going on with that child's involvement in those other systems. The diagnoses are different from adults. You know, ADHD, conduct disorder, anxiety, those tend to be more prevalent diagnoses. You know, diagnoses of psychosis, for example, are very uncommon in children. In the Medicaid population, those children who use mental health care, about 2% have a diagnosis of psychosis. And to improve the quality and cost of care coordination really has to focus not only on the child, but the whole family and the community in which the child lives. The American Academy of Pediatrics has documented that there's a high unmet need for care coordination for children with behavioral health challenges. That's especially true of children with significant behavioral health challenges because care coordination is not terribly effective, the usual care coordination approaches. So if we think of traditional case management or care coordination provided by managed care organizations, which tends to be more telephonic, much larger caseloads, or health home approaches for adults. So, you know, in these data below may be a little dated, but they aren't going to be that different. So if you look at the Missouri health home coordination rate, Missouri was one of the first states, if not the first, to have an approved health home by the Federal Centers for Medicare and Medicaid Services. Their care coordination ratio was 1 to 250, whereas a fidelity wraparound approach is 1 to 10. Payment rate, you know, we've done a scan around the country of what is the care coordination rate, a bundled care coordination rate, just for care coordination, supervision, etc., not for the services that are being used in fidelity wraparound approaches, and they tend to, you know, hover around $800 to $1,000 per child per month. Actually, some are even a little bit higher. And that's very different from a care coordination rate you will see for adults. So let's turn for a moment to the role of primary care. You know, 75% of children with diagnosed mental health conditions are seen in the primary care setting, and many families are comfortable accessing care through their pediatricians in a way that they may not be as comfortable accessing care through specialty behavioral health providers. And that's particularly true among racially and ethnically diverse families. And pediatric primary care providers, they're well positioned to identify problems early, and they are the ones that, for example, are doing screening through Medicaid's early periodic screening and diagnosis program. And of course, there's a persistent shortage of specialty behavioral health care providers just about everywhere, and which further argues for an enhanced role for the primary care sector to do more in children's behavioral health. Having said that, though, there have also been a number of studies that found that primary care practices can struggle with managing behavioral health conditions, and often it's because it takes more time. They're not incentivized to be able to spend that kind of time. They may not have the knowledge base. They may not have the staff support. So one study, for example, found that all behavioral health conditions except ADHD were associated with difficulties accessing care through a medical home. And furthermore, there are some populations, for example, racially diverse, lower income youth, and those with limited English proficiency who may not have a medical home or identified primary care practitioner. That's also true for the LGBTQ community of youth. So there are, these challenges. So what this expert convening was looking at is where are there promising practices around the country and what are they based on? And so team-based care integration within a primary care setting, like Elise is going to talk about, there have been data around it, particularly for certain populations, of its effectiveness, for example, for adolescents with depression or using office-based services. And the group also identified essential elements of collaborative care. And then for children with more complex needs, as I mentioned, they identified wraparound as, fidelity wraparound as an approach with evidence. So I'm going to stop there, and I'm going to now turn to Elise Faluco from Jacksonville, who's going to talk about their collaborative care initiative. Elise?
Thank you so much, Sheila, and I just want to thank SAMHSA and the TA Network for inviting me to present today. As Sheila already mentioned, I'm Elise Faluco. I'm a child and adolescent psychiatrist out at the University of Florida College of Medicine in Jacksonville, Florida, and I'm really pleased to present our model for taking care of kids with moderate severity mental illness in a large network that involves pediatricians and mental health providers. So, I just wanted to piggyback on what Sheila had said about the importance of working with primary care providers. So, the primary care providers are the ones who see the kids, who see them at least annually, and who have good, long-standing relationships with the families. And they have extensive medical training to be able to identify early signs of behavioral health problems. In addition to that, if you look at this horrible-looking map here of the United States, I just want to orient you to it. It's basically looking at the national shortage of child and adolescent psychiatrists state by state. And so the red states are the ones where there's a severe shortage, where essentially there's only, there's fewer than 18 child psychiatrists for every 100,000 kids under the age of 18. So I'm in Florida, which is one of those red states, and you'll notice you do not see any green states on there. So this is not a local problem, this is a national problem, and I'm really excited to see there are people here from Colorado and Connecticut and Wyoming and Texas, all of which are, or many of which are red states as well. So I know you're very familiar with this. So it's important to collaborate with primary care because child and adolescent psychiatrists and our child-serving mental health providers cannot meet the need through direct patient care. And so we need innovative networks and programs to help meet the needs of these children. And so essentially, the ultimate goal is that child-serving mental health providers can coordinate with primary care providers and basically leverage the expertise and connection of the primary care providers to serve hundreds and thousands of youth on a population-based level. So let me tell you a little bit about our collaborative care program in Jacksonville, Florida. So there's two key essential ingredients to our program. And the first one involves clinical training for primary care providers, and the second one involves outpatient consultation. And again, as Sheila mentioned, the primary care providers do not feel comfortable managing many types of mental health problems, in particular, depression, anxiety, and more severe cases of ADHD. And so, and this is through no fault of their own, a lot of this has to do with the lack of mandated training during pediatric residency and beyond in child mental health care. So essentially we have this large workforce of primary care providers who could promote early identification and care for some of these kids in their practice, but they just need the tools, they just need the right training to be able to do so. So part of our model is to provide that training, and then we serve to provide outpatient consultation. And we create, by doing so, we create this virtual network. So if you look at the slide, you see these, our collaborative care team is featured in the center, which involves a child psychiatrist, some therapists, sometimes, or a psychologist. And then we have these spokes of primary care providers who are all centered around us, who we serve as a part of our team. And the ultimate mission is that we're creating this virtual network and virtual partnership between primary care and child mental health providers so that we can collaborate to co-manage patients and serve a larger population. And I'll kind of walk you through what that looks like as we go on a little farther. And these are, oh, look, here's some nice animation. So the clinical training pops in and we provide consultation. Here's a nice map of Jacksonville for those of you who have not visited. It's northeast Florida by the Atlantic coast. And this is sort of a representation of the primary care practices who we serve. So each one of these tiny little colored flags represents a different primary care practice. And I want to emphasize that these practices are not part of an existing network. They are all a bunch of community private practices, as well as public health department practices. Some are academic practices. It's really just kind of represents the scope of our community. And so we, in order to be able to build our network, our integrated virtual system, we had to kind of start from the ground up and create the network from scratch. And I'll start by telling you a little bit about that. So, the first step to building this model is creating this network, building a team of child psychiatrists and child mental health providers and primary care providers. The second step involves training and then consultation, as I mentioned, with the ultimate aim of increasing access to mental health care on a population level. So step one, how did we do this? So we built this network essentially by going door to door to some of the largest pediatric practices in Northeast Florida. And we came to them saying, look, we want to be able to provide you the clinical training to care for more of the kids in your practice with mental health conditions. And honestly, if we're being very honest and frank here, they expressed a lot of reluctance about this and ambivalence, and they felt, very fairly that at the time, they didn't have the training and skills to feel comfortable managing kids with anxiety, with depression, and felt less comfortable about using certain medications. And so it was actually difficult to originally sell this model to the pediatricians. And what I learned in the process of focus groups and of working with specific pediatricians is that at the end of the day, they want to feel that they will have access to child psychiatry. And if you provide them the training plus access and give them a sense that they will be, that they will have backup when they start to identify and treat these kids, then they are much more willing to engage in this type of consultation collaborative model. So essentially, my pitch at the end of my experience working with this pediatrician so that I could sell the model was, one, look, the way things are now, it's very difficult to access specialty mental health care. You guys don't feel comfortable taking care of the kids in your practice, and there's this sense that there is no network or is no system to connect primary care with child psychiatry because there's limited communication between them. We don't share electronic medical records, and there's often this sense that you refer somebody to a child psychiatrist and either they never make it or they make it and you never find out what's happening. And so what I learned throughout all of this is we really, as part of this network, we really need to make sure that we're communicating, medically what we're thinking and communicating our treatment plans to our primary care providers in our team. So the second part of building our team was also making sure that we had the right mental health providers. If you look on the right side of that slide that says recruit TAPS, and TAPS standing for Child and Adolescent Psychiatrists, we really need to have mental health care providers who are interested in collaboration and in consultation and in teaching, and that this consultative model is actually different than how we are trained as child psychiatrists. Traditionally, as mental health care providers, we often see kids and families for years and years and years. And when we're talking about moving to a role where you're serving as more of a consultant, that means that you're going to have a shorter-term relationship with the family. And so, this model is a challenge to providers on both sides, both the primary care providers who are stretched to really practice at the top of their license in learning to take care of kids with with higher severity mental health problems, and then also to the child psychiatrist. So once we were able to build our team, kind of gradually get buy-in from certain pediatric practices from across the country, we piloted clinical training. And this is one of the parts that I'm really excited about, because I'm a firm believer in adult education. I think, and this is a little bit ironic because here we are like listening to a webinar and with PowerPoint slides, but one of the things that we know about adult education is that people need to be actively engaged in what they're learning, and they need a chance to ask questions and to try out skills and to really think about how to apply what they're learning. And so our clinical training, we tried to hold fast to that model. So we provided training for primary care providers to take care of kids almost across the lifespan. So, ranging from identifying early childhood problems in preschool-age kids to identifying anxiety and depression in our school-age kids and adolescents. And then we've also taught pediatricians how to assess suicide risk and to feel more comfortable managing that in light of the black box warning on antidepressants. The part that makes our training unique is that we really ask them to practice interview skills and to practice talking with teenagers about depression, about suicide, about some of these topics that are less comfortable for pediatricians, given their current training. So in this slide, this is actually a picture of one of our standardized patients on the left, the young woman with the hoop earrings and the kind of spiky black hair. And then on the right is one of our pediatricians from Central Florida. And so what we do in our trainings is we give these pediatricians 10 minutes to practice interviewing our teenage actors about different mental health problems. And we really challenge them, use this time as an opportunity to practice clinical skills in evaluating kids for depression, for suicide risk. Ask them about drugs, ask them about, whatever you need to, so that when you get back to your practice, your main private practice, your main clinical practice, that you will now have the experience and the comfort to be able to address these complicated issues. So we also provide helpful tools and algorithms for managing children and adolescents with mental health problems. This is an example of one of our pediatric dosing cards that we developed for the pediatricians to just help them as a primer to know how to safely prescribe antidepressant medications for depression and anxiety. And that's available off of our website as well. And so, Sheila had alluded to the evidence basis for this. So one of the things that we found when we started this program years ago is that the use of the standardized patients, or the SPs, was associated with, helped the pediatricians feel most comfortable in talking with adolescents about suicide risk. So if you look at this slide, just really simply, we randomized pediatric residents, this is back in St. Louis, to one of 4 groups. So either they were a control group and didn't get any education on depression and suicide risk. They attended lecture alone, or they practiced interviewing with the SPs alone, or they had a combination, which is our actual training that involves a lecture plus practice interviews with these standardized patients. And you'll see that it's that combination group circled in red that demonstrated the highest self-reported confidence in talking with kids about suicide. So we wanted to go beyond that and say, the ultimate goal in integrating care is to give pediatricians the training and the confidence to manage these children and adolescents with moderate severity mental health problems. But what we want, and we want to make sure that they enjoy it as well. So in this slide, I've highlighted some of the positive feedback from the providers that suggests that they felt it was worth their time to engage in this type of training. But ultimately, we want to know, how does this impact practices? How does this impact the care of the hundreds and thousands of adolescents that we saw on one of the earlier slides? So for this one study, we looked to see if training impacted identification of depression. And if you turn to this slide, what we did is we, over the 2-year period, we looked at the year prior to training and searched through the electronic medical record for 7,000 adolescent well visits, and saw that around half of the adolescents were being screened for depression in the year prior to training. And then in the year after this special training involving standardized patients, or SPs, we saw a major spike in the depression screening practices. And this improvement was sustained even 12 months after the actual training, which was really promising to us. And we've studied this, looked to determine longer-term outcomes, including 18 to 24 months following training in a separate study. And we found that the rate of screening for depression was sustained even 2 years after this training, which is very promising and hopeful, and really just emphasizes this idea that pediatricians are incredibly skilled and have an incredible opportunity to care for kids and families with mental health problems if they're just given the right training, the right tools, and the right environment. So the next step, of course, is to look to see not only are more adolescents being screened for depression, but is this resulting in improved diagnosis and identification and treatment of depression. And if you look at the slide on the left, is a little blue bar graph. What that does is it shows the percentage of adolescents who are newly diagnosed with depression in primary care following training. And you'll see that there's a spike that's maintained 2 years after training, such that at the end, about 10% of their adolescents at well visits were being picked up as having depression or newly diagnosed with depression. And then the pink bar graph on the right, the formatting's a little off on one part of that, but essentially it's showing that the adult 2 months after training, almost all of the 2 months after training and sustained up to 2 years after training, almost all the adolescents who were diagnosed with depression did discuss evidence-based treatment with their primary care provider. So in summary, as a result of this training, really what we're seeing is improved screening practices, improved identification, diagnosis, and treatment of depression that is sustained up to 2 years following the training, which is very promising. And so, and this is more data that's from a separate paper that again is showing significant improvements in the percentage of adolescents who are diagnosed with depression in the year following training. So what we really, kind of wrapping that up, we've talked about now in step 1, building the team and engaging primary care providers and child psychiatrists. And then we talked briefly about the clinical training with standardized patients. And now I really want to get to the outpatient consultation model, which is unique and different from some of the other statewide models that you have heard about in earlier versions of the care integration series. So the way our outpatient consultation model works is that these primary care providers who have been trained can refer their patients, see the nice animation, for consultation by our child psychiatrist. And we usually are able to maintain access so that these patients can be seen within a week or 2 of the initial referral. But the idea is that we are truly serving as consultants. So we will see the patient for an initial consultation and then up to 3 follow-up visits, with the ultimate goal that the patient returns back to the primary care provider for ongoing management. And this is really important because if we are able to see the patient, provide consultation, and then collaborate and partner with the pediatrician who takes over their care, then that allows us to maintain open access for additional children and adolescents who need care and further evaluation. So the question is, how do we make this work, and how does this work? Well, this is really best served for patients who have depression, plus or minus anxiety, plus or minus more severe ADHD. And this model does not really work well for kids who require very, very high levels of care, such as hospitalization. And essentially this is a little cartoon of Goldilocks on this slide. And you may remember that she talks about, she doesn't want anything to be too hot. She doesn't want anything to be too cold. She wants her porridge to be just right. And that's really what we have to do when we're triaging consultation requests from the pediatrician. We're looking for kids that are not mild severity, who could benefit from just therapy alone. We're also screening out children who require very high levels of care, such as immediate psychiatric hospitalization or more traditional psychiatric ongoing care. What we're really trying to do is find the types of patients and kids who are best served by the model, who have really moderate severity illness, who could be managed by consultation with the child psychiatrist and ultimately sent back to their pediatrician. So we see them, and we make, as I mentioned before, it's really important to communicate your medical and mental health findings to the referring provider. So we create detailed notes at the end of each assessment and make sure to send them to the referring pediatricians so that they know what we're thinking, what medications we're starting, which therapies we're recommending, and for how long. And the idea is, this helps with communication and partnership with the pediatrician. So we've studied this as well. This is currently unpublished data that we're looking at here, but this is long-term data. So of the 128 patients who were referred for consultation in this about 18-month period, we triaged them. We were not able to accept 30 of them, about 25 of whom required that higher level of care that I mentioned. That some of them we reviewed the referral request and said, oh my goodness, this child needs to be sent to the emergency room for more acute evaluation because they're very unstable. And some of whom had a number of risk factors and flags that would make them less suitable for ongoing collaboration between co-management between the pediatrician and the child psychiatrist. But and then 27 patients were accepted to the model, but then decided not to schedule an outpatient consultation appointment. So that left us about 71 patients who we saw or who were invited to be seen in clinic. And I want to highlight, if you look at that very last row in the slide, you'll see only one patient out of these 71 patients no-showed to their scheduled appointment. And that's anybody who's working in mental health care can see that's an incredibly low no-show rate. And so there's something very promising about this. And when we track these 71 patients over the course of time to see what happened to them, I'll draw your attention to the pie graph on the right side of the slide. What we found is that almost half of them were able to be discharged back to their primary care provider after consultation. The other half that's labeled in blue, it says that they're lost to follow-up, but what we found out since I submitted these slides is that actually a number of them did go back to their pediatrician who's taken over their management, but they simply weren't officially discharged from our model. So for example, we saw them for consultation maybe for one follow-up visit, and we said, come on back, and they, for whatever reason, the family didn't return to our care, but returned back to their pediatrician who's managing them. So that blue part of the pie actually should be a lot more green. And then if you look at the last little slice of the pie that's yellow, you'll see that there's only a small minority of these patients required ongoing long-term psychiatric care by our providers, which again, as I mentioned before, is really important because that tells us that the vast majority of patients who we're seeing are able to be seen for consultation, stabilized, evaluated, and either by default return to their PCP or are officially discharged back to their primary care provider, thus leaving us capacity to continue to see more referrals. And there's some more data in there that I'm not going to go into in great detail for time purposes. But so now, in summary, we talked about building a team, participating in training using the standardized patients, and then I've touched briefly on our outpatient consultation model. So ultimately, the goal at the end of this is increasing access to child mental health care on a population level for all of these kids who are being seen by their pediatrician, being cared for in the pediatric office, and even for those who are being cared for by the pediatrician but are deemed a little bit too sick or too difficult to be managed by the pediatrician alone, and are sent to our outpatient psychiatric consultation clinic. So I direct your attention back to the slide that I put earlier in the presentation, where you see that this model is a way to leverage the education, training, and clinical experience of a child psychiatrist to work with a large network of primary care providers, each of whom sees hundreds and thousands of kids. So it's a very resource non-intensive way to positively impact the mental health care that children and adolescents receive on a population level. This is one of our final slides for the presentation, and I wanted to close by just showing that, you know, the traditional model of mental health care actually has silos. So in this traditional model, you have primary care in the silo on the left that's in blue, and then mental health services in the silo on the right in purple. And what we've really tried to do through the North Florida Collaborative Care Initiative is to build a network, create a virtual network between primary care and child psychiatry, so that patients can be, you know, kind of go back and forth between primary care to child psychiatry, and then ultimately back from child psychiatry returning to the care of their primary care provider, so that you don't have children lost in the gaps between the two silos, but instead it's this continuous process where kids are being co-managed and they don't fall through the cracks, so to speak. This slide, it just lists, it shows our website, the partnershipforchildhealth.org. I think the / is actually Center for Collaborative Care, and you can Google it if you need more information. And that's our full website listed on this final slide. And to close, I just want to say, you know, this collaborative care model is really trying to work with existing systems of primary care providers and child and adolescent psychiatrists and therapists to create a virtual network that increases access through clinical training and outpatient consultation. So the next question is really for you guys across the country. You know, what can you do in your system in using the existing framework to improve access and care on a population level? And at this point, I just wanted to open the floor for questions, if there are any.
This is Sheila again, and I don't see questions in the chat box, but why don't we give folks a minute just to see if they want to enter any questions in the chat box. Please go ahead and type them in. While you're thinking of your questions and typing perhaps, I actually do have a question. I know that Jacksonville recently received another SAMHSA System of Care grant, and I believe that there are some plans within it related to your collaborative care initiative, and I didn't know if you wanted to kind of speak about what your future directions might be.
Yeah, so Sheila, it's interesting you would say that. I mean, I think now that we've worked with a number of primary care providers on caring for kids with moderate severity mental illness, and we've given them the training, tools, and consultation to help these kids, we're really pushing our providers and trying to see if we can scale them up to also be able to take care of kids with kind of moderate to severe mental illness. And so what we're doing with that SAMHSA grant, or part of it, is working at this one really high-risk population that takes care of homeless youth and their families through the Sulzbacher Center. And we in collaborative care are working to help train some of the providers at that center to take care of, you know, more seriously mentally ill youth. And in addition, you know, this is a little bit hot off the press, and I hope Dr. Jeff Goldhagen, my colleague, will be okay with me saying this, but we're also looking at taking this type of model into the schools and trying to empower teachers to promote early identification and recognition of kids at risk as well, in addition to the primary care providers.
That's great. Thank you. I see someone is typing, so let's give him a second. Are you concerned at all as you were you concerned, or are you still going forward, that this could create an additional demand on your behavioral health, your mental health service providers, not so much child and adolescent psychiatry, because you are kind of managing that, but in terms of children who then are needing therapy or other types of, mental health treatment services? Has that been an issue at all?
Yeah, that's a great question, Sheila, too, and one that the pediatricians also ask, like, by introducing these programs, I talked about adolescent depression, but we really have different programs across the lifespan to promote screening and early identification of problems. And so the idea is, okay, if, we know the program works if we're screening and we're identifying more kids who need treatment, but this is also a challenge because we know it's difficult to access treatment on a large scale. And so your question is well put, that are our therapists able to, manage the demand of some of these kids? And that's not a question we've systematically studied, but what we think is going on and what we hope is going on is that we're identifying kids earlier who are less severe, thus placing less of a burden on our therapists, as opposed to not screening, not identifying them until they've been untreated for so long that they then become so severely ill that they require more ongoing intensive management by therapists, by the hospital, by inpatient units and residential care facilities.
Okay, thank you. There is a question here from George Patron, excuse me if I'm not pronouncing your name correctly, but he says, we all should be using the patient-centered medical home approach, which integrates not only behavioral screening, but also treatment for same-day referral. How have you been able to overcome the, quote, productivity model of payment in the U.S. to provide this level of care before a crisis forces us to act? So, yeah, I mean, if you do get, you do hear that kind of sort of concern on the part of pediatricians that, they have 15 minutes per patient. How are they going to deal with an additional behavioral health screen, or the time involved in talking to a psychiatrist, right?
Right, and that's a realistic concern, and one that we've also looked at. So we know part of what our training involves is teaching the pediatricians to bill for screening, and certainly for the private insurers that works. They bill a 96127, which gets them $10 to $15 per patient screened. Now, for Medicaid, a lot of that is considered bundled in, and so they're not necessarily getting additional revenue for that. So that, the question is, how do you recoup this time? And again, it kind of goes back to this larger belief that if you catch them earlier, they are less sick and thus less likely to use intensive medical resources. So, for example, let's say you have a teenager with depression. If you don't screen and they go unrecognized, it's very likely that they're going to have multiple visits to primary care for abdominal pain, for somatic complaints, for headaches, for school absence, for other problems that require the pediatrician's time, and ultimately potentially could result in hospitalization. And so the idea is you invest time up front to screen them, identify them early, and get them set up with treatment outside of the primary care facility, and that somehow that frees up time. I mean, I think we do an entire webinar on what's the cost efficiency and how do you manage productivity in a short visit. But part of what our training tries to do is understand, we're not trying to make pediatricians into psychiatrists. When we train them in these skills, the idea is that they're practicing it in the context of a 10-minute well visit, so that it's something that can be practically implemented, ideally.
Yeah, interesting. Thank you. One more quick question before we turn to Oklahoma. This is from Jody LeBrun. With the shortage of psychiatrists and the majority of them working for providers that have wait lists or long waiting times, how have you been able to recruit psychiatrists in order to see referrals from the primary care practices within, a short amount of time, like within 1 to 2 weeks?
Yeah. So that we do not have a surplus of psychiatrists where I work at all, and in fact, I mean, it started with just me, and we've been doing this model for, I don't know, let's say 7 or 8 years, but in the first year that I was doing it, it was just me, and I had a limited amount of time. I blocked basically half a day of my continuity or of my regular clinic for collaborative care consultations, with the idea that I'm going to block a 1-hour visit for new patient evals or one 1-hour slot per week to see these kids. And if I don't get a new consultation request, then I will easily fill that 1-hour slot up with our other referrals to the clinic. So it's just guarding your time up front. And part of what we're setting in the model is seeing, so we're offering this expedited access with this special VIP slot in my schedule so that they can be seen within 1 to 2 weeks of referral. And because it's a consultation and that they're not engaging in traditional ongoing psychiatric care that lasts months or years or however long, that slot then becomes freed up after I finish the consultation or the extended consultation and then go back to their pediatrician. So that part of, does that make sense? I hope.
Yeah, that does. Thank you. And I think also, if people have additional questions around this, they can also follow up with you directly or pose them to us and we'll get them to you. We're going to now move, though, to Oklahoma, so Shamika Williams has enough time. Shamika? Yeah.
Thank you, Sheila. So Oklahoma has probably been in integrated care here now for the last 5 years. We started out, again, doing the integrated care through the systems of care model with wraparound service about 5 years ago. And as a part of that, what I'm going to share with you today is some of our clinical criteria, the different types of assessments that we use in order to determine eligibility. I'm going to share a little bit more in depth about our Ohio scales and why we chose to use the Ohio scales. I'm going to talk about the 2 levels of care, as Sheila mentioned earlier today, our moderate and our high intensity level, and then the different components of our health home teams. Some approaches that we actually use in order to determine everything from our rates and our ratios for services, and then I'm going to share about some of the different aspects and the roles of our health home providers. And hopefully from that you'll kind of get an idea of how we have structured all the way from the eligibility all the way through the service components, the team components, as well as some of the expectations for the outcomes that we aim to accomplish. Okay. Again, as you guys know about a lot of the research, specifically the research around kids who have severe emotional disturbances or kids that have been impacted by trauma. Our goal for this is really to begin to aid in the lives of those kids so that, again, that we work on the social, emotional, as well as the physical health so that our young people do not turn into adults who are SMI and have chronic health issues. As a part of through our systems of care, continuum of care, we began to build our wraparound model many, many years ago. And as we've worked with different experts like Sheila over the years, what we came to realize is the wraparound model is a really good model to use on an integrated approach, working with primary care and in primary care settings as well. And so in the state of Oklahoma, we currently use what we call our CAR assessment. It's our client assessment record, in addition to the Ohio scales as a tool to help to determine the risk category as well as to support the payment mechanism that we designed. We also have 2 levels of care. One we call our moderate level, which is more like a service coordination model, and then our very high level, which is our wraparound level of care for kids that are more on the high intensity. And people often ask me what really helps to, how would I summarize the 2 different levels? Oftentimes when you come across families that have real complex needs and families that have young people that have high behavioral health needs, a lot of those individuals will meet the criteria for a high level, as I'll go into that later on. But then also you may come across families that are at a high risk level but don't need the level of service supports that a wraparound level would need. And so a lot of those families will be eligible for some of our service coordination models. But as we go through the high risk, as we go through the different categories, you'll see how we basically determine eligibility utilizing different assessments as well. Our CAR assessment is also the assessment criteria that we use that is eligible for our Medicaid, our SUNA care. So it is a billable instrument. The CAR assessment looks at several different domains of functioning within a person's life. It has a scale that actually helps to determine the range of those functionings. We look at everything from the frequency, how often the behavior occurs, the intensity of the behavior, as well as the different symptoms that are impacting the behavior. The CAR assessment currently only consists of looking at those identified areas over the past 30 days. And so we only look back 30 days in each of the domain areas to look at intensity, duration in order to determine what the scoring is for the CAR. As you will see, the CAR domains really look at everything from the feeling, thinking to affect. It looks at everything from the family, substance use, role performance, we ask questions around school performance, interactions with peers, interaction with family members, and really based on the intensity of that, we have a scoring domain that we can come up with in order to determine a score. As you'll see, we have definitions for the different CAR domains that we look at, and it kind of helps you to determine how to ask questions around those areas. It also helps you to look at what specific information you may need to be gathering from those different areas, different measurements that you may need to look at in order to come up with your overall scoring. Again, it kind of continues and goes into everything from a child's basic needs, looking at not just the child's but the family's basic needs, everything from self-care, and then the role performance. That's where it goes into some of the aspects of school performance, home performance, as well as social performance, how they interact with their peers and other things. In the state of Oklahoma, we use what we call a client data core, which is a CDC. The CDC on the monitor is fairly small, but it actually covers domains of scorings from everything from trauma. In the state of Oklahoma, we have trauma assessments where we actually are able to gather information across the state about the kids that we're working with. We have information such as everything from identifying if there's homeless or housing issues, as well as different scores from screeners that would be substance abuse screeners that we can pick up. Our CDC in the state is specifically for all mental health providers across the state, and so there's different elements that we can actually gather from this tool in order to determine everything from where our kids are receiving services for, the types of services that they're seeing, the types of screenings, and other evidence such as specific outcomes, such as contact with law enforcement, as well as suspensions from schools and things that would help us to identify areas and ways to measure some of our outcomes. In the state of Oklahoma, we chose to use the Ohio scale. You go click through here and bring the whole screen up. The reason why we chose to use the Ohio scale is because, for one, the Ohio scale was really not, there was no accreditation requirement for the Ohio scale. It was pretty much a quality tool that we could actually utilize on a large scale, a statewide effort. The scale had 3 different types of measurements that we can look to gather information from the perspective of a parent or a caregiver. It also gave you the youth perspective as well as a worker perspective. So the worker, as the worker worked with the young person over time, would be able to provide some valid information as to how they actually see some of the different challenges that the youth was facing. The Ohio scale is pretty simple, so when asked some of the questions to the parents or the caregivers, it was pretty understandable. And then also, as we've worked with the developers, it really had some good growth and research. There's constantly new information coming out around the Ohio scales, with Brooms as the developer of the scale. And it was pretty much a nominal cost. So when we looked at over time the implementation of that, it was not very expensive to utilize. The Ohio scales, it has two different functions that we pretty much pay attention to, and it's the problem scale and the functioning scale. And as you will see on the problem scales, the questions are fairly simple questions. Asking questions about how the young person performs in different environments. Do they get into fights? Do they yell and scream? Do they lie? Do they have self-harming behaviors? And so again, from a scale of not at all to all the time, a 0 to 5 scale, it was very easy to articulate to the parents as well as the youth around some of the questions that we were getting at. Again, on the Ohio scale, when we look at the problem scale, it allows us to pick up information like internalizing behaviors, things that may not, externalizing behaviors, things that could potentially be visual to the eye, but then also there were some questions about feeling and thought that would allow us to get to some of the internalizing behaviors, things that we often see in our younger girls. There are scales that would provide us information around delinquency, such as, some of our kids who were maybe breaking laws or doing some violations in school or curfews or things like that. In addition to that, there's also a resiliency scale. And so when we start looking at factors around if our kids are getting better in certain areas socially, the resiliency scale is a scale that we can look at in order to help to make some determinations around some of the questions if, in fact, our kids have if we can infuse and continue to work on areas of resiliency. I mentioned earlier there's a lot of research that goes on around the Ohio scale. And again, there was a study done in the State Department of Texas Mental Health on the Ohio scale, which actually helps us to identify specific areas of impairment or clinical impairment or borderline impairment. The scale is a 20-item scale. I mentioned earlier, it really focused on problems and functioning, and the scales basically give us a borderline from 0 to 25 if a person is functioning fairly well, or 25 or above if a person is clinically impaired, and then there's a borderline scale. So again, these scales can be rated in order to help us to determine where our young people are at the particular time of assessment. We also have used the Ohio scale in the state of Oklahoma since the inception of our systems of care back in 2001. And as a part of that, we do what we call a wraparound fidelity index, which is a WIFI. And so this particular slide is a slide where we actually looked at 12 of our counties, and we looked at a baseline of youth, and then gradually have looked at youth over time to look at how many of those youth showed some type of impairment, but as well as when they were reevaluated within 6 months, what the level of improvement was. And so as you'll see, that there's the percentage of improvement shows significantly improvement on a scale of everything from about 78% all the way to 50% for the 12 counties that we surveyed. And so we've done some test studies with the Ohio scale, some case studies with the Ohio scales over time, and done some publications in order to show you in a care management fashion how we have been able to utilize this as a tool to look at how our young people are improving over time. And so as we talked about the CAR score, the CAR assessment as well as the Ohio assessment, these are the tools that we utilize in order to help us to determine the eligibility for our young people in our health home system. As a part of that, that is a part of our initial treatment plan. The initial treatment plan is done as a comprehensive care plan where we work with every component or every individual on the team. You'll see, I'll talk a little bit later about the nursing assessment, the primary care record, Also, we'll talk about the integrated care plan, the child and family team plan, the wellness self-assessment and management tool. How do we incorporate health and wellness and the 8 dimensions of wellness in the overall aspect of the plan, and then also the health risk appraisal. And so again, we consider all of these as a component of our comprehensive care plan for the individuals that we serve, for the young people that we serve. We have 2 categories that we look at. In order to be, the determination for each one of those categories is slightly different. But in order to be a part of our health home, you really have to have an active, comprehensive person-centered care plan. There has to be a plan in place that actually drives direction for the care for the individuals that we see. In addition to that, you have to provide at least the minimum requirements in order for health home services. As you'll look at our wraparound level, we do have a required number of hours that an individual has to be seen in order to meet the requirements for that level. And then the frequency of contact. We require face-to-face visitation. We have phone calls. We want to make sure that the individuals are referred for other services that have been identified as a part of the care. And then also there's a level of care coordination where we're working with the primary care providers, where we're working with hospitals and other inpatient facilities to make sure the care is coordinated, regardless if they go into an inpatient setting or an outpatient setting, regardless if they need dental care or they need other types of care. And so again, you will see how some of our risk categories actually determine everything from payment and where a person can be within our 2 categories of care. Our moderate category is pretty much, it really requires an extensive level of systems coordination and really engaging with the behavioral health provider for children and families, as well as coordination, facilitation with primary care. It also requires that a young person meets an eligibility based on the CAR level. They have to score at a level 3 in order to receive the moderate level, which is an intensive service coordination level. So they have to score at a level 3 or greater in order to be eligible for the moderate level of care. And so that's based on the CAR scores. The CAR scores would have to identify the level of care, which would have to be 3 or greater. On the high intensity level, it's a little bit more restrictive. And the high intensive level, it's pretty much the wraparound level of care. In this wraparound level of care, the individuals will have to score at a level 4 or greater. In addition to that, they would have to show some type of impairment on the Ohio scale and underneath the problem or in functioning. The services that would be required for this high-level wraparound is a minimum of 12 hours per month per family. This would include a combination of everything from face-to-face visits as well as some additional phone visitation and other services that you can receive within a health home. In many cases, when we look at the young people that are at the high level, level 4, needing the full wraparound, these young people are often involved in other systems that would require some type of coordination, whether we're talking about probation and parole, whether we're talking about a specialized IEP plan. We often see young people at this level that are in and out of inpatient types of care. The kids that we work with are often engaged in multiple systems, have had contact with law enforcement, may have come across our crisis system on several different occasions. And so again, they're much more at an intense level of care and need some type of coordination of care as intensive as wraparound. As you'll see, some of the areas that I've already mentioned, hospitalization within the past 3 months. They can also have some type of chronic health, physical health conditions such as diabetes or asthma or other conditions in order to meet the level of care. They are also often at risk of being placed in and out of community placement. Sometimes our young people are really on the edge of being placed in a group home type of setting, shelter setting, or some type of incarceration type of setting. And so again, we're talking about youth that are at a much higher need or level where they need a level of intensive coordination, such as what a wraparound level of care would provide. Our Children's Health Home team is pretty much a real comprehensive team, and this team is a combination of, we have an actual supervisor, the clinical supervisor that we call the project director. We have care coordinators, family support providers. We have what we call behavioral health aides as well, and they are our children's health home specialists. They work on the health and wellness side for our young people. The team also consists of a nurse care manager, primary care physician consultant. All of our kids have the ability to be consulted with the primary care physician. And then a psychiatric consult. We have a lot of kids that are in our level of care that are high, that are on medications, and in order to manage those medications, as our health homes do, we have physicians as well as psychiatrists that we consult with, and psychiatrists that prescribe the care. The overall goal with this is really to create a unified plan. We want one plan that drives direction for this child and family, and that consists of all system partners, so that a kid is not engaged in multiple different plans and trying to jump from the different hoops in order to accommodate the different plans. Again, we have different approaches that we use through our health homes. We require that there is what we call health home huddles. Oftentimes, health home huddles are done frequently in the morning at each of our sites, where they really come together, may talk about a different crisis call that happened overnight. They may talk about a direction for the day, or maybe a mother has called with a request. Oftentimes, we come across young people where the parents are not quite sure if a symptom is a behavioral health symptom or a symptom is a medical symptom. And so, again, to have the ability daily to flag some of the critical or the high-need areas for the young people that we have in care. These health home huddles are at each of our sites, and they have the ability to do that. We also require that they have team meetings. As you'll see in the team meeting category, it can be everything from updates, reviews, case reviews, information from the team on an action plan for the case, keeping everybody in the know, and keeping everybody on the same page. We have case conferences, is where when the whole team is involved, oftentimes what you'll see at a case conference is the ability to discuss something significant where all team members need to be involved in. It can be everything from a reaction to a medication. It can be onset of some type of health issue where some type of action needs to be done fairly quickly, and an action plan needs to be put in place. Or it could be something that is where the team needs to talk through how to get more momentum from the family. Maybe the momentum is getting the family to follow through, making their appointments, maintaining their physical health appointments, especially if the kid has a chronic health issue. And then also we do celebrations. We often encourage our staff to celebrate their successes. We've had a lot of scenarios where our young people who have come in and found out some of their symptoms were symptoms of diabetes, and they needed to follow up with their primary care. We've had youth that have lost significant amounts of weight. We've had kids that have been able to be stabilized in their homes, in their communities, and out of inpatient for quite some time. We've had stabilization in schools where kids were able to function in a school environment in order to be able to maintain. We've had kids that were on the edge, on the verge of going into the juvenile justice system at a higher level, group home or institution. So we've had some really great outcomes in our health home model, really, as we've been able to focus on the entire child, the whole child, not just the behavioral health, but the whole experiences. We've had some scenarios where, because our young people are working with a psychiatrist in our health home, and who's managing the medication, Oklahoma is a very rich state in Native history. We have 38 federally recognized tribes, and oftentimes there's herbal remedies that families use as a culture, and so some of the times those things offset with some of the medications, and to really have the ability to have that cultural inclusion as a part of our team, it has really helped the young people that have been offset by some of those herbal remedies that were counteracting with their psychiatric meds. And so to have those things to come together for us to really begin to identify where the problem is and get those families back on track has really been huge. Again, this talks a lot about our ratio. As we prepared our payment mechanism, the ratio for actual supervisor, 1:8, the number of care coordinators and the number of cases, as well as working with a family support provider. It talks all the way down to the ratio for our primary care physicians as well as our psychiatric consults. Again, depending on the individual cases will depend on how often a consult might happen. If you have a kid with a high-end health condition, that kid may have that case manager or their care coordinator may have a consult with the primary care physician a lot more often than the 0.5 hours per year. Again, that is per population, and so it's important that for our kids that don't have high-end physical health problems that we maintain them on a regimen of seeing their primary care doctor and even identifying their primary care doctor and not utilizing emergency rooms for their health care, and so making sure that they stay on a preventative measure. And then also our high intensity. Our ratio for our high intensity is much higher. You'll see smaller caseloads because the intensity of wraparound is very much an intensive process. And then earlier I mentioned the average per youth per family for all services is a minimum requirement of 12 hours a month. And so it is a very intensive process. 8 of the 12 hours have to be face-to-face, and then also weekly contacts. And so again, this process is much more intensive than you would see at a moderate level. Again, it kind of goes more into the primary care and the physician requirements. It talks a lot about our nurse care manager and the requirements for that, for that role and what they do. They consult with the psychiatrist. They help with the planning. Again, if our young people come into care and they don't have a primary care physician or we haven't been able to get them in to see one quickly, our nurse care managers are able to do our wellness assessments in order to identify if there's any type of healthcare concerns that we need to look at immediately and maybe expedite to the emergency room. But overall, what we try to do is get our kids in to see a physician as quickly as possible. We also work with our nurses in order to assist our families with immediate care. So sometimes our families will call in with concerns, and our nurses are able to contact them back to say, yes, you need to go to the ER, you need to go to the emergency room. Again, numbers and oversight for our physicians, who they are. They have to be board certified, and how they are, the requirements for them consulting on cases. This next slide is just really a team comparison slide. It kind of talks about the overall team and the expectation of the team for each of the areas and the transition and how they work in the community with the different schools, juvenile justice, as well as our DHS. This next slide is our payment slide. It talks about our different payment mechanisms from our urban to our rural areas for both of our high intensity as well as our rural model. Our high intensity as well as our moderate rates. And you'll see those rates are per month rates. You know, one of the things that if we was to go back and talk about what we knew and what we didn't know, I think that in the state of Oklahoma, really engaging better around primary care, really having conversations about the exchange of information and how important it is to help families to understand better some of the medical concerns that they have, how important it is to make sure that our families are consistent with their appointments, to make sure that our primary care physicians are sharing information from discharge from an inpatient or an hospital setting. Because what we want to do is we want to make sure that we are helping our families to follow up with their health care concerns as well as their behavioral health care concerns. And then also just the sharing of different medications that are taken from a mental health perspective as well as a physical health perspective, and making sure that the healthcare providers understand the psychiatric medications as well. And then also, understanding that, this is a journey for us. I think it's important that we figured out that a checkup from the neck up is just not good enough. We need to treat the whole body, the overall well-being of a child. And so, again, as we have had experiences with this, we continue to learn daily. We continue to move in the direction of a state that's looking at what we call CCBHC, Certified Community Behavioral Health Center, as a stepping stone from our health home. And so the integrated care model has been a model that we greatly value in the state of Oklahoma. We feel like it has been a model that has shown really great outcomes for the kids and families that we've served.
Thanks so much, Shamika. We have very little time, but there is a quick question about, of the 12 contact hours, is that between a care coordinator and a family support?
Yes.
Okay, thank you. There are a couple of other things. Dennis Calcutt, I think if you email Elise Faluco, she can let you know about the training for primary care docs. And Lori, the care coordination continuum, this was a nice question to set up. This last slide in here, I think, is in here. There's a full report from the Expert Convening, and here's a link to it, which defines terminology and puts that graphic of a care coordination continuum into a context. So I hope that that's helpful. And let me see if there are other, I think there are other questions. I do want to thank our faculty for presenting and for all of you for listening. Again, please feel free to reach out to any of us. Our contact information is on one of the slides, I think. Yeah. So, okay, well, thanks very much, everyone. And I think, Tiara, is there anything else we need to know or do?
No, thank you everyone for joining today. Please stay connected until the very end so that you can take a short 5-minute survey. And that survey will pop up as soon as we close out of the webinar.
Great, thank you. I forgot to say that in the beginning, so thanks for reminding everybody to do that survey. Okay, great. Thanks everyone, and have a great rest of the day. Bye.